Hi, everyone. My name is Nicole Ladon. I'm a senior health scientist in the Division of Adolescent and School Health at CDC, and I'm going to be presenting information to you today on the programmatic activities that DASH suggests for local education agencies to improve student access to sexual health services, or SHS, and also some ways that state-level groups like yourself can support those efforts. So most of my experience with this work is doing research in the field of adolescent use of preventive clinical services in general. But in DASH, my colleagues and I provide extensive TA to LEAs that we fund on the ways that we can improve student access to SHS. So I wanted to state that just to let you know, I'm not a state policy expert, but I do have seen firsthand how our local education agencies sometimes struggle to advocate for adolescent sexual health service use in ways that some states are supporting efforts to overcome them. So next slide. So with this in mind, I'm going to start by describing DASH's programmatic approach for our local education agencies to improve student access to SHS. By providing an overview of our activities, I hope to give you some idea of what CDC is asking and expecting of our local jurisdictions. Within a few of these activities, I'll pause to highlight examples where we've already seen policy impact implementation, sometimes for the better, but often as a challenge, and give you some examples of how certain of our funded LEAs are working within their own policy landscapes. And then we'll conclude with some thoughts we've had in DASH on potential state-level actions to support localities and improve implementation that I hope can help you. Next slide. So first, I'd like to just give you a general overview of our framework for our program guidance. And that is that we ask a number of activities of our local education agencies that fall within what we call 3 buckets or 3 main areas of work. And these are to strengthen staff capacity, to increase student access to programs and services, and then also to engage parent and community partners. You'll actually find if you look at DASH programmatic guidance that all of our strategies fall across these 3 main areas of work. So for SHS, here are the 8 activities that we ask of funded LEAs. Some of these are required and some are optional or additional. And I think it's important to tell you that some of these additional activities are deemed so mainly because state-level laws prohibit their work. For instance, if you look at number 6, excuse me, about implementing school-based screening events, and number 7, to implement or improve a condom availability program, these are largely limited by state laws against either conducting STD testing on site or providing condoms at school. So we can't ask all of our funded LEAs universally to work on these because some are prohibited by law. Next slide. So for the sake of time, I'm going to focus on just a few of these here for which we have some good examples of how policy and state or partner support helped with program practice at some of our DASH funded LEA partners. Next slide. So I'll start with an activity that some of our LEAs choose to implement, and that is to establish or improve use of a referral system. The goal here is to connect students to community providers or school-linked clinics offsite. And in doing so, we've created a referral system that it can consists of 7 core components that you can probably barely see here in this graphic. But is part of a referral toolkit that we have on our DASH website that you can take a look at. And all of these core components can be driven by policies that prohibit provision of services. Next slide. I want to talk about one example at a state level, and that is the case of California, where they have a state law, California Education Code 48205, that requires schools to excuse students from school to attend confidential medical appointments. And that is, these are largely services that they have a right to self-consent for at certain ages. I think in California, I believe it's 16, it may be even lower. And schools cannot require that parents or guardians give consent for these services, nor can they notify parents or guardians about the student's use of those services. So this is a state level law that we noticed was being implemented and used at varying levels across the state in different local jurisdictions. And that is largely because it really created some questions like, what is an excused absence? How do schools verify that this excused absence is indeed for confidential health services that the student is attending? And then how do they document those excused absences, especially given that they have certain protocols for documenting other kinds of absences for which parents are notified? So in recognizing a lot of the questions that were coming from schools and districts, the National Center for Youth Law, located in California, created a resource called Confidential Medical Release, frequently asked questions from schools and districts to help with implementing at a local level. So this is a screenshot, just part of the table of contents from that document, and shows you some of the kind of information that the FAQ addresses. And there's some great detail in here that can provide you additional resources as well. Moving on. So the next activity that I want to talk about is a student program to improve use of school-based health centers. These are health clinics that are often located on-site or maybe nearby a school that provide needed and critical healthcare to students, including sexual health services. So what we were asking of our local education agencies to do in order to ways that they could improve use of SBHC was to increase the types of services that are provided at an SBHC, to ensure that students have privacy and confidentiality around sexual health services, ensuring that clinics are adolescent friendly so that the students would come and use them, implementing a standardized sexual risk assessment or a sexual history taking of all the students that come in for any reason, and then also just generally improving awareness of SBHC services among both the students who would be using it, but also the staff who may be directing students to health services. So that's what we want our LEAs to do in terms of their SBHCs, but how we want them to do this are through a number of different ways, including maybe policy change, quality improvement projects, or simple awareness campaigns within a school setting. Next slide. So some of the policies that impact SBHC is that most states really have no policy and neither require nor prohibit provision of SHS in schools. Typically, decisions regarding provision of services or referrals are really the jurisdiction of the local school boards. But most states do have SBHCs that provide needed SHS. But of these, only 65% provide STD and HIV testing. About 80% provide pregnancy testing, but only about 60% provide HIV testing. So to address sort of this need for lack of services, sexual health services provided in SBHCs, I wanted to tell you about the DC Public Schools and DC Health. They formed a partnership in an effort to increase the scope and reach that required actually their SBHC providers to offer LARC insertion on site, to expand services to feeder middle schools. So these are SBHCs that are located on high school settings, but they actually changed their policies to allow for the feeder middle schools to also attend SBHCs. And then the LEA actually had to provide some transportation for those kids to get to the schools. And then also they had to participate in DC Health's STI screening program. So they were really trying to leverage some other programs as well. And these were all enacted into a policy that if a health provider wanted to come into a school and provide services at an SBHC, which they worked through DC Health to do, they had to offer these services or have these programs in place. All right, so the last programmatic activity I wanted to talk about was for us to ask LEAs to implement or improve CAPS or condom availability programs. And these are visuals of some materials that we have on our DASH website about CAPS, including some general talking point, and important talking points for stakeholders, including how research shows that CAPS are associated with increased condom use among sexually active students, but they do not increase sexual risk, which is a common concern of the public and often parents and stakeholders then. So our website has this information. We also have some information from a science brief that outlines a systematic review of CAP literature and some important program considerations for your districts who either want to implement or improve a CAP. We also have what you see on the bottom right in terms of a success story in our funded sites in the case of New York City. So next slide, and I wanted to go a little bit more in depth into New York City and why they've had such success, and that is largely due to some of their policy implementation. So all high schools are required in New York by the New York City Department of Education, their HIV/AIDS prevention program, to train staff and run what they call health resource rooms, or HRRs. And these HRRs are required to provide students with condoms, with health information and health referrals. Some of the other policies related to HRRs is that parents can opt their student out of receiving condoms, but all students may receive the information and the referral to health services from these resource rooms. They also did something neat in that they paired their HRR services with state policy related to their HIV/STI prevention education. So all the information that they're providing there are within the sexual health education requirements at the state level. That is, they can't teach about something that they're not allowed to teach about in the classroom. And then also following some lag in the CAP implementation, that is establishment of the HRRs and provision of condoms. Once they got that set up, they realized that they needed to advertise these health resource rooms and the condoms more widely. So they started a marketing campaign. Okay, and before we move on and before I finish up, I just want to highlight one major policy realm that you should think about because it impacts adolescent use of sexual health services very broadly, regardless of the school setting or clinic setting. And that is the issue of parent and minor's right to consent. I talked about this a little bit in the case of California, but there are state laws that impact provision of confidential services, and you should be up to date on them. In general, states recognize the need to allow minors to consent to testing, treatment, and care for many SRH or SHS services without parental consent or knowledge. So in general, about half the states allow minors to self-consent for STD and contraceptive services. Sometimes that language will vary. For instance, it may be framed as preventive services, or it may be framed as treatment services. So STD testing may not actually be covered by an adolescent right to self-consent, but the treatment would be. So it's a little bit of a sticking point. And then the age varies, as I mentioned earlier, state to state. I will note that awareness of these laws is really low among young people, their parents, and school staff. So one thing that you could do is to look at your state laws around adolescent right to self-consent, and built into that is parent notification, and ways that you could possibly improve awareness of them. And then also say that sometimes though, in school-based settings, these laws and policies may contradict, may be overridden by the local policies. So implementation could be an issue. So I just want to wrap up to talk about real quickly some thoughts on some state level opportunities that you could use to support local practice in your state. That is, you could identify the local needs and what is feasible. You could help them interpret state level policy with some guidance and tools that I suggested earlier. And you could also develop implementation tools to raise awareness, create model policies for local agencies to use, or FAQs on confusing or complex policies. Then I list a couple of resources here that I mentioned in the presentation, and I'm sure we can share these more broadly because they're kind of hard to read. And then if you have any more need for more information, here are some places you can go, or you can actually email me. It's not listed here, but it's nliddon@cdc.gov. Thanks and have a great day.